Welcome to the Shockwave Therapy Podcast. My name is James Woolidge, osteopath and clinical director at the Abbeyfields Clinic in Suffolk. We will be trying to demystify the concept of shockwave treatment whilst bringing together experts in their field to discuss the latest research. If you are deciding on whether to add this modality into your clinic or just improve the way you deliver it, then we hope this is the podcast for you.
Right, thanks for coming, Stuart, on tonight's podcast. I haven't done one in ages, but we've just been at Innovations, which some people might have heard of on this podcast, which is a sort of Venn Healthcare Stork-sponsored weekend. Once a year, we all get together and discuss what's going on. And, you know, me and you have been to all five, I think. We've taught at most of them. And I had a few people come up to me, which was really nice, saying, you haven't done a podcast in a while. And I have probably been sidetracked by our other venture, which is ED clinics, right? So we're doing a podcast for that now, which is based on, you know, men's health and urology and so forth. But I thought that a few people had asked me, and I then asked, you know, what kind of things do you want to talk about? And one of the things that came up after your talk, which was on how to maximize plantar fasciitis outcomes with Shockwave, that I'd get you on again. For those people that haven't heard you before, you were on this. You must have been my second or third person on guest on this. Yeah. Probably some of that, right? Yeah. So, and at that point, had you had your focus device? I think maybe not.
I've had it about 6 years.
Oh, so you were ahead of all of us pretty much, right? So
we had it at the same time. How long ago was yours?
I think mine might only be 4 years ago. I got my focused, maybe more, maybe 5 years ago now.
I was first in the group, but
you were,
yeah, but not much.
Sorry,
not by a long time though.
No. But I think when we talked about Shockwave before, which got me thinking with this other guy saying, oh, maybe you should do something on that, because plantar fasciitis is the most common thing that we see, right? That if people say Shockwave, they kind of go, plantar fasciitis. And then there's you and I and a few other people spouting on about Peyronie's disease. And everyone goes, hang on a minute, you know, everyone's basic case list, you know, for this sort of Shockwave stuff is plantar fasciitis, lower extremity tendinopathies. So where we chatted last time, I think we would have been talking back in the old days where, you know, radial was supposed to, you know, liven up the tissues, do other sorts of things. And things have moved on a little bit then. And if you've got focused as well, can you just, because you've taught this a long time, could you just give a quick summary in your mind about what the differences are and how we now use them and combine them even?
Yeah, well, I mean, I use the radial device more as a scanning device and for the surface area tissue.
Right.
So it's kind of, I use it to cover larger areas. Then I use the actual treatment in my head, the actual focus device. So I kind of combine the two together. But whereas before, when we came on the podcast last time, when we were talking about things outside of plantar fasciitis generally, like kind of first joint neuromas and things like that.
Yeah.
Now talking about plantar fasciitis, I'd have treated, I used to have 20, 21 patients a day, plantar fasciitis at one point.
Yeah.
And like, you know, I'd treat them all with radial, and, you know, I was getting very good results at that point.
Yeah.
But, you know, there's no comparison when you've got the two there. I kind of use the one for the surrounding tissue, and then if the actual pain sites, I use the focus to deliver more. Well, first of all, it's the depth of the treatment is better, but second, the quality of the treatment is better, I feel.
Yeah.
And also all the research. The research is based on focus shockwave at the end of the day.
Yeah. And so your talk at the weekend, which opened my eyes a bit. So I'm going to start changing the way I treat plantar fasciitis on the back of it, because I was always a bit dubious about treating the widespread area. And you talked through what you did as a process, which was really good. And you also mentioned this bit of research where they've done a really good quality RCT comparing treating plantar fasciitis with treating just on its own, the plantar heel, and also combining it with treating the calf. Now, what just remind me what that study was?
So, I mean, the first study was the fact that the calf actually had an influence on the gastrocnemius had an influence on the foot pain itself. And then kind of we're looking at the studies within that, and then the stretching studies aren't very conclusive. Sorry, my dog's just walked in.
That's all right. I think it happened in the last podcast.
Does it all the time, yeah. So the stretching kind of didn't show any real significant. There's 2-3 studies out there, meta-analysis that shows that stretching doesn't really help with it. So we do a lot of hands-on therapy, and I have patients who've had plantar fasciitis 2 years, and I haven't even touched the foot. I treat the calf, and it clears up. So to me, it's pretty obvious the cause and effect.
And do you use just your hands-on for that, or do you use the radial device as a sort of myofascial treatment?
I combined. So I scan the tissue with maybe a hands-on device like a tool assisted, and then I go on with 2 or 3 different various fascial techniques, but then I overlay with Shockwave as well to break down any fibrosis. You can feel the scar tissue and the fibrosis, and when that breaks down, the symptoms come a lot less. Yeah.
So that study that was done.
I always explain to a patient, if I pulled your hair from here, it wouldn't hurt here. It would hurt on the insertion, and that's the same paramount to what we're doing when we're doing the plantar fascia. I'm loosening the calf up, which takes the pressure off the downstream, and then it reduces the pain in the plantar fascia.
Right.
I think especially when you're going through Baxter's and tarsal tunnel, because I think there's a pull on there that then goes and does a referral pain into the heel, which is picked up by Shockwave. So, it doesn't necessarily come up in a scan or an MRI, but the emphasis on the heel can be non-reactive with Shockwave. Okay, that's the way they're complaining the pain is.
Yeah.
But then you scan it with the Shockwave. I scan 3 or 4 different points.
Is that with a focus device now? Or you scan it with the radial?
I'll start with radial, then I'll check both. But I scan it quickly with the radial. If they jump through the ceiling on a low setting on a radial device, then I take note of that, and then we come back to it next session.
So you choose to go back to the calf again. You're scanning the calf for areas of tension that you say would probably, which makes sense, have a pulling effect down into the plantar fascia, but also you're scanning for areas that might be giving referred pain down through into the heel.
That's correct. Yeah, there was Secco, who does the myofascial stuff. He did a study, and can I just reference it because it's not one I kind of look at.
Yeah, sure. And we'll put these up into the podcast, into the writing up afterwards. Anyway,
no, I was going to do it on another computer, but I couldn't get Zoom working on the other computer, so I kind of did it on this. So plantar fascia. So 2021 Tugnole. Treatment of myofascial points with ESWT in subjects suffering with plantar fasciitis could be an effective treatment offered. So basically, he's saying there's a global biomechanical effect in effect.
That's different to the RCT one that you talked about as well. That's just his observations, was it?
Well, no, it's a study.
Right. Okay.
It's a randomized control.
Oh, so that probably is the one I'm thinking of, where he compared that with just treating the plantar fascia on its own.
Yeah, and basically that with favourable results. Yeah,
gotcha. So in your experience now, it's almost standard that you treat. You don't just wait until they're really chronic and they're the ones that are difficult to get better. Your standard approach is, I'm always going to do this through the calf. I'm going to scan for it and treat that as well as treating the heel itself.
Yeah, I mean, the first session I do a biomechanical assessment, see what's going on.
Right.
If there's anything outstanding, or I kind of ask them to do different exercises to kind of compensate that.
Right.
And maybe some of them to do with the calf and releasing the calf. Then the second half of the session and the first session, I scan the different areas and get reaction points. I take note of what the score is on the Shockwave machine, and I write it down the area, the pressure and the machine and the head, and then that's my reference points from when they're starting.
Right.
Then the second session they'd come in. We'd look at the second section and we move on to the calf then. So then we spend maybe first 10 minutes, quarter of an hour, half an hour session. I scan the calf pretty quickly, try and break it down depending on how severe it is by different methods of fascial release. I'll put a cup on them normally if I find an area that's problematic, leave the cup on it to do some work while I go and treat some other part, then come back to it and then Shockwave it. And then we go to the foot and follow up from the week 1. So week 1 would be then, say, tarsal tunnel showed up quite severe, then we'd work on that.
And would you, because you've been doing this a lot of time, you probably, as a podiatrist, see, obviously lots of people come see you for this, but I'm assuming, like the rest of us, when we've got, let's be honest, slightly flashier kit than other clinics and we're experienced, you tend to see lots of other people's failures where they've come to you after seeing 3 or 4 other clinicians. In your experience now, would you say that the failure in them to get better is more at the fact that they haven't had the biomechanics sorted, orthotics or otherwise, or more because they haven't had a thorough, as in treat calf, treat all the other stuff approach? What would you say is the more common thing that they're failing on?
I don't know if it's a combination of the two, really. I mean, I had a patient recently who'd seen someone for about 3 years, 3 years that had PRP injections, steroid injections, and then referred to myself, and like literally 2 to 3 weeks, this patient was better. And okay, I changed center of mass and how they're distributing weight on the foot.
Yeah.
And I think that has a big part in it. But the reality is I think, when they were doing the PRP injection or steroid injection, they were probably going into the emphasis where they're getting the pain. And okay, it might be showing up on an ultrasound. But the reality is when I put the Shockwave on the tarsal tunnel, they went through the roof. And also the calf was heavily fibrotic. The hamstring was heavily fibrotic. So yeah, it's not even just the calf. If things aren't going my way,
the whole posterior chain.
Yeah, I move up to the hamstring next.
Okay. Well, that brings us on to this the other one that we were discussing as well at the weekend. Was this rather brilliant trial done by Dylan Morrissey, and that was in the BMJ, wasn't it? Which was this really nice bunch of RCTs, meta-analysis, combined with interviewing patients about what they thought was the best treatment for their plantar heel pain. And I bring this up,
experts as well.
Yeah, an expert opinion, right? So I bring this up sometimes when I get a bit frustrated because I'm like you on a few podiatry podiatry Facebook groups and so forth. And everyone seems to still be, which I know you get frustrated by, they're either in do orthotics, and that's the answer to all things, or equally, there are some people now that have a Shockwave device and just Shockwave the sore bits. And they're in that camp. And you go, well, all you need to do is look at some really good up-to-date evidence and say that actually what patients want, what experts agree on, what the RCTs all agree on, is that actually focused on all radial devices, because they were included in that RCT, weren't they? Both types, plus a bespoke orthotic, is exactly what you should be doing in combination, isn't it? I mean, does that frustrate you a little bit when you hear those stories?
Yeah, my main criticism of that paper is that okay, all right. If you had plantar fasciitis coming on today, James, what would you want to do tomorrow or today?
If my own heel was sore,
yeah, what would you do for yourself?
I'd stick my Shockwave on it and make myself an orthotic.
So why are we waiting for 6 weeks?
Oh, I see. That's your point. Sorry, I was a bit lost there because you agree the paper's good, right?
But yeah, the paper's good. It looks at. I think it kind of takes some pretty low evidence and kind of gives it clarity. It gives it clout where it maybe not have it. It kind of says like taping is great, and that should be a first line. When the evidence is a bit really hit and miss, it's not that great.
Yeah.
Less than a week and low evidence, moderate to low. Then the same with stretching, the same with insoles. The evidence is all hit and miss. The only one thing that is definite is the Shockwave, realistically, and that's got 20 years of backing from all.
But isn't it the combination of you've still got to think about their biomechanics as well with an orthotic?
Yeah, well, even the orthotics wasn't amazing, like kind of the outcomes on that. It was with the night splint, it was quite good when you put the two together.
Yeah.
But then who wears a night splint? Well, I think my point in it is that a lot of the stuff is like moderate to low evidence.
Yeah.
And I'm not saying you shouldn't use it. Combination therapy is the best. You do everything you can because each person might have a slightly different variation on why they've got it. So if you can change that, the way they're loading pressures via an insole or taping or stretching or whatever, that's good. So I'm not saying not use the other things. What I'm saying is that to me the front line should be the Shockwave. The acute, if I had plantar fasciitis, I'd want Shockwave on it because it even works better. The studies on acute versus chronic on plantar fasciitis, whereas we all used to do it in chronic 6 months plus. 2 treatments failed. So it was amazing it even worked in the first place. Let's face it, it had the hardest of the hard cases.
Yeah,
It
yeah,
was still succeeding.
yeah,
But the reality is now we've gone past that. The studies out there showing that the sooner we get at it, the better
yeah,
the outcome and the quicker
yeah,
the outcome.
yeah.
So I don't know why they're kind of putting it at the 6-week point.
I think that was based upon the fact that all of the initial evidence that came out for shockwave therapy, I think, was based upon the fact that the equipment's quite expensive. And I think they were reserving more expensive treatments for those patients that hadn't got better by normal means within, i.e. people tend to get themselves better regardless of intervention within about 3 months, right? But certainly I now agree with that in terms of, especially those groups of patients where we see for recurrent problems, they come back 2 years later, 3 years later, because now we've both done this 10 years plus. They'll come back 3 years later, but they'll come back 2 weeks into a new episode. And you treat them then, and they need 1 session or 2, and they're done. And of course, that makes sense, right? But I think that we've so got stuck with the initial trial data that came out that said it's for 3 months plus. I think we've somehow contorted that in our minds to say, well, that means we can only treat those. No. All it's saying is that the initial data said you've got to be 3 months plus, because that's where the trial data sat. Didn't mean to say that
it's 6 months, wasn't it then?
Wasn't it? Maybe back in the day, it might have even been longer. But that's
when
not. There was a suggestion that you've got this biological problem that is better for shockwave. No, you haven't. It's much easier to do shockwave with someone acute. It does help having focused shockwave with that, I have to say. But now I treat everything regardless of time. I just hopefully only need to see them once or twice, and then that's it, right? That's your job is done. Talking of that, the way that things have moved on since our last podcast. What's your view? I mean, so if you take that plantar fasciitis now, particularly if it's a chronic one and you've got those areas into the calf and the heel, the other thing that people still get caught up on is this sort of weird magic number that everyone talks about. It's, 2,500 shocks for the plantar heel. I thought your place would do that. So give people a little bit of an update on where we are and our thought process on that, and what do you use?
I mean, to me, I think I got used the protocol in the first month or so, and that was about it, really. Ever since then, it's been cause and effect of the patient. You kind of follow the patient's pain. If it's 4 to 6 pain, you go with it. With the D20, I'm probably looking for 1.8 on a radial. On a on a focus, I'm looking for 0.20-25. And if you normally get to
0.2 or 0.25 on a plantar fascia.
Yeah.
Do you?
Yeah, it clears up.
That's a lot of wincing, I would have thought. I'm not sure I've ever gone that high on a plantar fascia.
You go with the patient. So first session, maybe it's 0.5.
And how many shocks would you be applying to this group?
It depends. I mean, if it's on a lower setting, so say 0.7 or 0.10 or something like that, then we're looking at 500, and then I'd want to move on or until dissipation of pain.
But that what I said to you at the start, the 2,500 shocks. Let's say most of the people listening to this have got a radial device, and we did the initial. I think did you do some of this stuff on a CERT, the trial back in the day?
I was on it, yeah, but
right. Then you'll remember that it was all 2,500 shocks. Yeah. That was it for each condition. What would you say your average is now? Yeah. What was your average? What would you say you're now at when you're dealing with a plantar fasciitis? Would you go beyond that?
It depends. I mean, if you've got involvement in tarsal tunnel, plantar fascia, the fascia, and the back of the calcaneus, then I'm shockwave in 4 areas. Then I'd probably be dedicating about, and it depends on the movement, on how the pain subsides on the patient. So I kind of shift between one to the other depending. It's very much patient-based.
Yeah.
It's a technique of shockwaving rather than an amount of shots. If I had to say an amount, I'd probably say, because the thing is, I'm building up. So say they can only take 0.5. So that's 400, 500 shots. Suddenly I try it at 0.7. Oh yeah, they can tolerate it now. So that's another 400 shots.
Yeah.
I'd say 2,500, but they're not static at one level. Generally,
but that's on a focus device.
On a focus, on a radial, I'd kind of been looking to scan the area and maybe give 1,000 at most.
Right.
I don't really stay long with a radial.
So I think I've definitely come to a point where some of those conditions, the more chronic, and particularly with insertional stuff, which we're not talking about today, but you could argue that a plantar fasciitis is an insertional enthesopathy, couldn't you? But certainly Achilles tendinopathy insertional, I end up with a focused using it quite often 2,500, 3,000 shocks at about 0.03, 0.05, because they can't take that much energy. And then I'll be radialing the calf and the actual mid-substance, probably Achilles, for another 3,000, 4,000, going on a bit of a journey like you suggested. And I look back to those old days where everyone's so structured and the machine settings are, 1,500 shots. That's what you get. And you go, and then you get all these questions, on Facebook, whatever. I was going, what should I do? What should I do? And you go, no, what? Just if it takes 2,500, 3,000 to tackle all that area around the heel, do that. And certainly with insertional Achilles, I think that you need to do at least 6 to 8 sessions at about 3,000, 4,000 each session before I start to get reasonable results, because they're so hard to get better. But back in the day, we'd have said 3 to 4, 5 sessions, maybe 1,500 shots.
It's very regimented. I mean, but I said in the presentation at the weekend, I said, you look on the internet, and I saw somebody saying, well, you can have 3 to 5 sessions, and it's not limited. It depends on what the patient needs. Some patients get better in 2 sessions or 1 session. Some patients take 8. You've got to. It's totally patient dependent. To me, you learn how to shockwave, and then you apply it to the individual patient.
Yeah, no, that's, I suppose, the point where we all get to when we get meet together and go, what do you do for that? Well, annoyingly, the answer so often in things that we do is it depends, doesn't it? But certainly not getting stuck to this idea of 3 to 5. And I think that's what I probably wanted to take away from this today, to be the fact that since the last 3 years or 4 years since we last time spoke, the idea of treating it in a specific way, in the ways that we were taught, has now moved on massively, to the point where, number one, go with patient feedback. Patient should lead you to where those pertinent areas are around the heel. And if you just go onto the central part of the heel or the medial part, you may not be hitting any of those bits that are relevant, right? And certainly that new trial coming out, which was compelling, about you've got to treat the calf. The calf treatment leads to better success with those really stubborn plantar fasciitis problems. That was I think the key point from today. You've got to treat the calf. And as as I think you should be in the wherewithal to make sure that you're more stubborn.
The ones that are more stubborn than me, that I reduce the pain in the local area, but for some reason they're not quite going, or it generally invariably is like I've missed something. So if I've missed the tarsal tunnel, I haven't been doing that properly, or the hamstring quite a lot of the times.
Can I ask you what's your target within the tarsal tunnel? Do you just focus for that?
You
think you're treating the tibialis posterior a little bit, or
it reacts in that area? What's reacting, I don't know. I think it's a potential referral from Baxter's nerve, maybe, but I don't know that. But I know that if you treat in that area, it can clear at the bottom, or it doesn't shift.
Did you say you did treat that with focused, or did you treat that with radial? Or
I start with radial, and I get a feedback, and then whichever one's giving me a feedback, I stay with. So if radial gives me a feedback, I'll try and shockwave with that. But then if focused gives me a feedback and radial doesn't, I'll treat with the focus. But I scan with both, and then I treat with whichever's reactive.
I'm assuming that's pretty low dose around the tarsal tunnel, because that's a sensitive old area, isn't it?
Yeah, but I also want to know that is a problem, because I don't want to be. I want to, if it needs treating, I want to treat it. And I think that's where I've made mistakes in the past. I've kind of gone over it, been a bit half-hearted, instead of, well, is it reacting or isn't it reacting?
Right.
So I normally start with the D20 1.4. It obviously depends on male, female, size of the the area and stuff like that. But generally, if you get a 1.4 plus or minus 2, you and you get a reaction, it's something that I want to treat, and that's improved my success.
Yeah, you do talk about the tarsal tunnel a lot. Would you say that's the best bit that you've learned over the last 4 or 5 years?
Sometimes it's. I went on a course with Dave Cashley, who does a lot of manipulation, and he was saying, without any of my intervention, that he feels back at the calcaneus sometimes, like lower insertion Achilles, even to a degree, but a bit lower maybe. That he feels that you get referral pain from that point, and I'd go with that point as well. I think different people, different things. There's some people it's tarsal tunnel. Sometimes it's the actual plantar fascia. further up on the fascia line. Sometimes it's calcaneus, and sometimes it's just the emphasis where the actual pain is.
Yeah.
But I think if you just choose one spot, you know, I think, you know, you potentially could be hanging around for a long time doing it with some people.
Oh, yeah. Okay.
It's very quick and easy to check those areas. You just go over it quickly.
Yeah.
If it reacts, you go back to it. If it doesn't, move on.
Have you got any more teaching coming up this year, or are you done for this year?
We've got a low limb specialist advanced course. So that will cover. I've included that what we did last week and I've added a little bit more for the lower limb advanced course, which is the end of this month or beginning of next, I think. It's on the Venn website, and then I'm teaching the Shockwave Essentials as well.
Okay, so if anyone wants to know that, then yeah, go to venhealthcare.com, isn't it?
Yeah,
and I'll put a link on the bottom of this, but it might this podcast is only going to come out in about a week or 10 days, so people might miss it, but hopefully they won't.
I think it's pretty well booked up from what
is it? Okay, fair enough.
But you know, that'd be good if we could have some more, and then I think they've already set up 2 or 3 for next year of the advanced.
And you're at Therapy Expo with me, aren't you? November?
Yeah, looking forward to it.
People can come bother us with the 2 bald blokes on the stand. Right, on that note, I'm going to say goodbye. I'm going to go and have some ice cream. And thanks for coming on again. I'll see you in another 4 years.
Take care, James.
Cheers, mate. Thanks. Right, that's us.